Welcome to this chest-themed AGR video article. I'm Jonathan Chung, Professor and Division Chief of Cardiothoracic Imaging at UCSD and the chest section editor for AGR. It's my great pleasure to welcome our video article authors, Dr. Jared Christensen from Duke University and Dr. Ashley Prosper from UCLA, who are both on the Lung-RADS committee. Dr. Christensen is chair and are also the first two authors on a recent review paper published concurrently in both CHEST and the JACR, which summarizes the current evidence and expert consensus supporting the new version of Lung-RADS. As a disclosure, I am also co-author of that review and also I'm a member of the Lung-RADS committee. So just as a quick introduction here, Dr. Christensen is a professor of radiology and the imaging director for the lung cancer screening program at Duke University. Dr. Prosper is an assistant professor at UCLA. She's also lead investigator of a large $2.7 million grant-funded project, which leverages the high adherence to breast cancer screening guidelines to improve adherence for lung cancer screening. So anyways, just to break the ice here, my first question would be a little bit more lighthearted, just to kind of get everyone comfortable. Can you tell us all something about yourselves that is not on your CV so we get to know what makes you tick? Let's start with Dr. Prosper.
Well, thanks for the warm introduction, Dr. Chung. Little known fact, I started my career first paying job as a child actor in a Twix commercial.
That's wonderful. I'm gonna have to Google that. I'm gonna find that video.
That's great. For me, I think before I decided to go to medical school, I actually studied architecture. So when I eventually became exposed to radiology and medical imaging, my creative and scientific worlds collided, and it really was a perfect fit.
Awesome. Well, so let's get into the meat of things then. So with the new Lung-RADS guidelines, what do you think are the biggest changes to lung cancer screening for radiologists? And Dr. Christensen, let's start with you.
So I think one of the most significant changes in the Lung-RADS 2022 update is the addition of classification management criteria for atypical pulmonary cyst. We also expanded criteria for airway and juxtapleural nodules. We introduced the concept of step management and provided additional guidance for potentially infectious or inflammatory findings at screening. And then we also provided some clarity around other issues that had been brought to our attention by those in practice. And so it really was a substantial update, and we're happy to have been able to bring that forward.
Dr. Prosper, among the major changes to the new Lung-RADS guidelines, the introduction of the juxtapleural nodule, at least for me, as a benign finding, similar to the periphyseal nodule, is probably one of the more impactful ones because of how common these juxtapleural nodules are. Could you provide for us the details on the criteria for juxtapleural nodules and potential pitfalls to avoid?
So we give some guidance in Lung-RADS 2022 as to how to identify these likely benign nodules. And I think that it's a nice extension of earlier Lung-RADS guidance, including version 1.1. So what we advise is that if you see a nodule that is less than 10 millimeters mean diameter, not only does it need to be juxtapleural in location for us to make this determination, but it has to have a few additional characteristics, and that is that it should be solid, smooth, ovoid, lentiform, or triangular. And so you're really paying attention not only to the location, but also size, density, and shape. So I think when people hear juxtapleural nodules, because of the name, undoubtedly, people think of location first, but all of these other characteristics are important. And so you want to make sure that all of those boxes are checked before you put a nodule into this category.
As Ashley was doing such a great job describing this, I thought it would be important to point out that this is a perfect example of the way that Lung-RADS develops, is that with version 1.1, we had data around periphyseal nodules, which justified the inclusion of benign criteria. But at the time, we didn't have data for other juxtapleural locations. And so by the time version 2022 rolled around, there had been some additional studies in the literature that really supported that we could apply the same criteria and do so safely. And so we try not to make assumptions, and we really do rely on an evidence-based approach.
I was going to echo exactly that. So I'm glad that you said that, Jared. There are several papers that are cited in our Lung-RADS 2022 manuscript. And if you have the opportunity to read through those original manuscripts, looking at large cohorts of patients with juxtapleural nodules, you'll see that they did large statistical analyses to identify the shapes that can safely be called benign. So, for example, there's the study by Hammer and Hunsaker. Dr. Hunsaker is another one of our Lung-RADS committee members, as well as a paper by Zhu et al. And you can see that when these juxtapleural nodules didn't have those shapes, just as you gave that example, Jonathan, they may not have been benign and may have shown growth potential and had turned out to be something malignant. So we're relying on the evidence here.
Okay, next question. And so this kind of piggybacks off this last question because we're talking about the mean diameter. What about volumetrics? That's the question. People have asked me about this. So my formal question is this. The widespread use of volumetrics in early lung cancer diagnosis has been touted as the next evolution of lung cancer screening. But as the field of radiology evolves toward a more quantitative and data-rich specialty, it seems like we really haven't emphasized volumetrics in the new Lung-RADS guidelines. So can either of you explain the rationale behind this lack of emphasis?
I do think it's important to acknowledge we recognize the potential value of quantitative nodule characterization, specifically volumetrics. We know that the Nelson trial validated that volumes can be used to characterize nodules. It reduces false positive rates in screening and directs management that reduces lung cancer mortality. What I think we have to be careful of is assuming that, for example, the Nelson study showed a roughly 25% reduction in lung cancer mortality compared to only 20% in the NLST, which used mean diameters. And so I think we really can't infer that that difference is attributable specifically to volumetrics over mean diameters. Those patient populations were very different. And so what our approach is, again, been driven by looking at the available data. And while there are advantages to volumetrics, currently I think the availability of such tools is limited out in many clinical practices. And honestly, we don't yet have any data that shows that volumes are superior to mean diameters in patient outcomes. In fact, there's only been one study that has actually looked at cancer detection rates using both mean diameters and volumetrics. And it actually found that mean diameters perform better at detecting lung cancers. And so that may be interesting, but it still doesn't answer the larger question of whether one method over the other saves more lives. So we're consistently looking at the data around this.
And I would just, commend Dr. Christensen and all of my fellow colleagues on the Lung-RADS committee for keeping a really important principle in mind, and that is that Lung-RADS is designed not only for the subspecialty radiologists, but for all radiologists who might be interfacing with a lung cancer screening exam with different skill sets and different resources. So not everyone has a PACS that allows them to do volumetrics on the fly. Not everyone has a 3D lab to help them create these volumes. And so we're trying to provide a practical guide that, sort of meets the lowest common denominator when it comes to resources. So I'm hopeful that technology will catch up with our demands and we'll see more streamlining of an approach to create a volumetric measurement, but we're not quite there yet across the country.
I was just going to say, I think you bring up an important point that, again, in clinical practice, there's a lot of heterogeneity, not just in interpreting radiologists, but also in the equipment. And so, for example, the Nelson study, it was the same scanner, same model that these exams were performed on, and they had a centralized group that was doing all the volumetric analysis, which in clinical practice, that really doesn't exist. There's a lot of heterogeneity. And so, again, having these really thoughtfully evaluated empirically is going to be important as we move forward.
So recent evidence suggests that only a small fraction of those who meet the criteria for lung cancer screening are actually being screened. In your clinical practice, have you guys seen volumes grow? And has it been incremental? Has it been exponential? What is that sort of rate? And then some other piggyback questions on top of this. What do you think are some barriers to screening? And then are there any opportunities for us as radiologists to help improve the uptake and adherence to lung cancer screening? And so maybe we could start with Dr. Prosper.
This is something I spend a lot of time thinking about. So if we look across the country, we see that our uptake rates for lung cancer screening amongst those who are eligible are what we would call woefully low. So depending on the data set that you look at, or who's done the analysis, we're going to see an uptake rate anywhere around 4.5 to maybe at maximal 6%, really low percentages. And if we compare that to other screening exams, for example, you mentioned my work comparing breast cancer screening uptake and lung cancer screening uptake. With breast cancer screening, we're seeing numbers above 70% of those who are eligible getting screened. So there's a huge potential, and we have a long way to go. So when I think about this challenge, I think of a couple of different factors. One is that lung cancer screening is new. So we think about the NLST being published in 2011. While a lot has happened and a lot has changed since 2011 in terms of, adopting a whole new image-based screening exam, it's not that long ago. And it was only in 2014 that we saw, Medicaid and Medicare cover this exam. So we have to have a little bit of patience. But I also think that there are a few unique challenges with lung cancer screening. One being that the eligibility criteria are a lot more complex than any other image-based screening exam, and that you not only have to assess age, you also have to assess when someone began smoking, smoking intensity, whether they're currently smoking or if they've stopped, how long ago. And each of those questions requires time to sit down with a patient and to accurately assess. And there are some current challenges with accurately recording that data in the electronic medical record. So in some sense, it's hard to even know how many people are truly eligible across the country. One of the things that I think radiologists can do is to really serve as partners with our primary care physicians. So rather than pushing this problem off onto our primary care physicians, partner with them and say, what can I do? So there have been several centralized programs that have developed where the shared decision-making process, the means of going through the risks, benefits, and potential outcomes of cancer screening for lung cancer are discussed with the patient. That responsibility can be taken on by the centralized lung cancer screening program rather than leaving that up to our primary care partners, because it takes time and it requires specific documentation. Other things that we can do are making sure that people know about this exam. So one of the challenges is just simply awareness amongst potential eligible participants. Finally, I'll discuss some differences in just geography. So I'll admit I'm from the state of California, and I'm a very proud Californian, but we have the lowest lung cancer screening uptake rate in the country. So what we're doing is we've banded together as a University of California system through what we call the University of California Lung Cancer Consortium. We have a specific focus on lung cancer screening with a task force. We're trying to leverage all of our UC cancer centers to come together with a plan where we're not working individually, we're working as a group to try to share resources. So I see this happening successfully across the country, where people are sort of letting go of self, letting go of ego, and saying, how can we work across health systems to share resources, because everyone's facing the same challenges. So I'm I'm concerned about the low uptake, but I'm also optimistic.
Ashley, that was very thorough. And
Oh,
I wasn't going to point out that California was last, so I'm glad you brought it up. But I mean, North Carolina, our uptake is about 7%, which still isn't that great, but that actually puts us in the top 11 in the
yeah.
United
Wow.
States. And all that really says is that there's a lot of room for improvement. And with that, I can speak to our program. We are still seeing year over year exponential growth in screening. And quite honestly, the thing that is kind of limiting us most is just our capacity. So, trying to increase capacity and access for CT scheduling, our screening clinic, even faculty recruitment to some extent. We are just trying to have the infrastructure in place in order to meet that demand and to help the program grow. Um, as far as barriers, I think so. Ashley alluded to several of these, but I tend to break them down into patient barriers and physician barriers. And one of the strongest that we hear consistently from the patients is that there's a stigma associated with smoking and lung cancer. And many patients say that they're kind of afraid to be screened, not only because they actually may have lung cancer, but if they are diagnosed with lung cancer, a lot of them are apprehensive about how they'll be treated. For example, no one blames a patient if they develop colon cancer or breast cancer, but there's a lot of shame associated with the diagnosis of lung cancer, which I do believe is a barrier to lung cancer screening uptake. And physician barriers, I think, include just a lack of time for patient encounters and a lack of up-to-date information. So our primary care providers have a lot of competing health priorities when they meet with patients, and lung cancer screening just isn't at the top of their list right now. Many physicians are still unfamiliar with the eligibility criteria. Several surveys have shown that some physicians don't know this service is covered by insurance. There's also a sense that annual screening places an additional burden on providers. And as Ashley previously mentioned, there is some burden with screening, lung cancer screening, with shared decision making, which really other screening modalities don't have. And I think that as radiologists, this is an image-based screening study. And so we need to take ownership of this. We need to be partnering, as Ashley mentioned, with our primary care providers and even our specialists to educate patients, educate providers, and be at the forefront of screening advocacy. And that also, I will say, includes within our own institutions. So being able to effectively advocate for the resources that are necessary to make screening a priority is really essential to providing this important service.
That's great information. Wonderful information. Thank you so much for that. Like I had one idea I've always been trying to get off the ground, which I think requires actually a pretty big resource, is trying to get a CT scanner that one could use for lung cancer screening on the back of an RV or some sort of large truck. Because I think one of the barriers
Yeah.
that I hear complain about a lot, including people that I know, people that are part of my family, is that no one wants to go to the hospital. No one wants to go. It ruins their day, right? And so, what if you brought the hospital to the patient, right? So, at these festivals, maybe like labor unions when they have their meetings, even even some areas where people can't come to the hospital for one reason or another, like prisons, right? You can go to prisons. Like a lot of people there are in need of lung cancer screening. So, what if we had sort of like areas we thought outside the box and we had sort of these devices that could bring again the CT scanner to the patient rather than the patient to CT scanner. So, with the national shortage of radiologists, is your practice using any diagnostic aids or any sort of algorithms for lung cancer screening? With the advancement of AI and machine learning, how might these technologies be integrated into lung cancer screening protocols to improve accuracy and efficiency?
So we use an AI-based algorithm to improve nodule detection and reader efficiency, but that's basically the extent. We actually don't have automated volumetrics or measurements. It's really just to detect nodules, and so I think there's room where we could expand that in our practice. We do not use software that automates the classification for lung cancer or Lung-RADS purposes. So the software doesn't tell us what Lung-RADS category it would be. And we also don't use AI that generates reports, although I know that that's available. And so we're still on the very early adopter or early curve of what's available in our practice. I do think that AI will have a greater future role in lung cancer screening in a few respects. So one, I think we'll eventually move to kind of big data driven approach for determining eligibility. Right now, we rely on age and smoking history, and that's a good start, but it really is inadequate. We know that about 15% of patients with newly diagnosed lung cancer are never smokers, and we're seeing national trends toward lung cancer occurring in patients under the age of 50. So our current eligibility criteria really doesn't capture at-risk or the entirety of at-risk patients. So I think that AI in conjunction with clinical and biologic factors could actually really have an important impact in determining eligibility and personalizing risk. And the second area is I think we'll continue to improve in AI diagnostics and move beyond just mere nodule detection or nodule kind of measurement and quantification to really getting into more kind of risk assessment and determining probabilities of malignancy as well as outcome stratification. And so not only will we be able to identify nodules that are cancer, but maybe even determine which ones have a high likelihood of progression or more aggressive behavior. And this may be particularly relevant for subsolid nodules, which can be there for years before becoming clinically problematic.
That was such a thorough answer. I'll just admit that we're in a similar state of early adoption at my institution. We are not currently using any AI tools for our lung cancer screening exams, but we're always looking. And I think there are a couple of challenges with AI adoption in this space. One is simply funding, right? So if you think about acquiring an AI tool, you have to find funding to be able to acquire that tool and to purchase it. And with the current way that we, bill for professional services and exams, there's not really a lot of additional room, right? So you have to be creative in how you fund those acquisitions. And the other is ease of use. So whenever I, discuss software utilization with my faculty, one of the questions is how many additional clicks is it going to take to get to the page that's going to help me out? Am I going to have to launch another browser? Am I going to have to do another login? So my hope for the future, in addition to those that I share with Dr. Christensen, are that these things will move in line so that they're seamless, so that we can be more efficient. Because again, if we think about the rate of lung screening uptake where we are right now, 4, 5, 6, 7%, if we get up to the numbers that mirror those of, say, breast screening with 70%, we're going to have more exams than we can know what to do with our current staffing. We expect a large physician shortage come 2036 of anywhere from about 13.5 to 50,000 physicians, depending on the numbers that you look at across all specialties. So we're going to have to get better at doing more in less time, and I'm hopeful that AI will help us do that.
I don't know if this will be relevant or not, but I wanted to add that so we've already seen some AI applications from researchers at MGH and MIT who have an algorithm that can predict where a cancer will develop even before radiologists can detect a precursor lesion. So this is now moving beyond like, oh, here's a nodule, what can you tell us about it? This is like, there's nothing there, but the patient's going to develop a cancer in this location. And I find that to be just really mind-blowing.
Well, I would say that's an active area of interest for myself and my colleagues at UCLA, is looking at some of the research applications of some of these deep learning and machine learning models to try to better characterize and prognosticate nodules that we're identifying. I think, Lung-RADS is doing an excellent job of providing a safe means of nodule management. But, these are based on the tools that we have readily available right now, right? Size, density, location, rate of growth. But I hope that we'll get to a point where, radiomics and machine learning algorithms are embedded online so that we get additional nodule features when we're reading these exams to help us better identify who needs to be acted on more quickly versus who we can, safely surveil for a long period of time. So all sorts of questions with these AI tools. I think we all have high hopes, and we're probably all pretty tough critics when it comes to evaluating them. But, we're just at the beginning. So I imagine the way that we're practicing will look quite different in 5 to 10 years.
So why don't we talk about now how the new Lung-RADS guidelines impact the follow-up protocols for detected nodules, especially regarding the new model of step management. This was a new idea that was brought up with this iteration. And then can you also summarize for the audience what step management is, as many of them may not be familiar with this concept? Dr. Christensen, maybe you could start with this one.
I think I'll answer your second question first, and that is, what is stepped management? And so the concept is, I think, fairly straightforward, is that when we have nodules that may be suspicious, identified as screening, after short-term follow-up, if they're stable or decreased in size, instead of just automatically going back down to a Lung-RADS 2 with a 12-month follow-up, we're actually going to step down to the next lowest category. So if it was a Lung-RADS 4A and it's stable at 3 months, then we'll drop it down to a Lung-RADS 3. And then they'll come back at 6 months. And then if it's stable at 6 months, we'll go from a Lung-RADS 3 to a Lung-RADS 2 and see them at 12 months. And this really allows us to safely kind of assess these more suspicious nodules in a timely manner. We'll see some additional time points where we can intervene if we detect any concerning changes. So that's the overall concept of step management. And a key adjunct to that is actually the timing of those follow-up studies. And so in the prior versions of Lung-RADS, the idea was the timing was always based from the baseline study. And so if you had a patient that was having an interval follow-up at, say, 6 months, but maybe they didn't come back until like 9 months, then they would have to actually come back in 3 months to have their annual screening study. And that just didn't make any sense from a clinical standpoint. That's the way it was done in clinical trials, but we know that clinical practice is different from a controlled, highly regulated clinical trial. So we felt that this made a lot of sense. We did some modeling to kind of assure ourselves that this would be safe. And so that's the concept of step management and why it was introduced.
I'll just add something that I think is maybe helpful as you're considering the impact of step management. And this is something that I'm borrowing from Jared. So we could consider 2 scenarios that we discuss in the paper. So one of the things that we know is, despite our best efforts, adherence to follow-up recommendations is not always perfect, right? So let's say you have a Lung-RADS 3 nodule that should be surveilled again in 6 months. If the patient doesn't come back right on time, let's say they come back in 9 months, the original recommendation in our prior Lung-RADS guidance was that the patient, if that nodule was stable, would return to their annual screen, meaning 12 months from the initial exam. So if they came back late, you would be seeing them really soon. So just 3 months after that 9-month follow-up for something that you're not terribly worried about. So you end up imaging, or you would potentially end up imaging people more closely than potentially you needed to. And then the converse was true with our more concerning nodules. So say a 4A lesion that you expect to see back in 3 months, on the prior versions, if that was stable, having them come back for their exam 12 months from their initial scan, you'd have to wait 9 additional months to see that concerning lesion again. So I think this gives us more leeway to be more conservative with nodules that we're less worried about, and to have closer follow-up of nodules that we really are more concerned about. So I think it fits better with the risk assessment that the radiologist has when they're reading the exam.
Wonderful insights here. Thank you. The next question I want to ask is about specific patient population. So, is there a specific patient population or populations that might be particularly affected by the changes in the Lung-RADS guidelines? And how should radiologists address these differences in their practice, if any?
I think one of the biggest changes is for how we handle potentially infectious or inflammatory findings. So Lung-RADS 2022 gives a lot more leeway for the interpreting radiologist to do a short-term follow-up for something that's potentially a bronchiolitis or mucus plugging with distal airway obstruction, without having to fit it into a Lung-RADS category. And what I really enjoyed was hearing feedback on this at our RSNA meeting in 2023, and hearing how people are using this additional leeway. And one of the comments that I heard was, you know what, if we have an automated letter system that automatically mails out results to patients, on prior versions, if I was measuring a nodule that I thought was infectious and it fit it to a 4A or 4B lesion, that patient's going to get really concerned about potential risk of cancer, when I really know in my heart that it's probably something infectious. So now opening up that Lung-RADS 0 category to say, I'm going to defer a Lung-RADS score at this time. We're going to do a short-term follow-up and then fit this into a Lung-RADS score once things have cleared up and the patient has been seen by a physician, maybe treated for a potential infection. I think the messaging that patients receive is so much more gentle and less concerning, because the last thing you want to do is scare someone for something that's really probably benign, induce a lot of anxiety, and then maybe have them not come back because the experience was so traumatizing. And we need patients to come back annually as long as they're eligible. So we want to make sure to only raise the red flag of alarm when we're really concerned.
Thanks, Ashley. The infectious inflammatory change also was immediately brought to mind with this question. The other thing is, I was at a meeting recently and heard some international presenters talk about cystic lung cancers, and they presented data that it appears that cystic lung cancers may be more common in younger patients in some populations, which currently would not necessarily be captured by screening eligibility criteria. So that was the other one that kind of came to mind, is that we now introduced atypical pulmonary cyst and classification and management criteria for those. But all that being said, I think in general, the Lung-RADS classification and management criteria, they tend to be agnostic to patient demographics, whereas the eligibility criteria are not. And we've already talked a little bit about some of the limitations of current eligibility criteria. I do think, at least in North Carolina, where we do have a fair number of underrepresented minority patient populations, having the expanded U.S. Preventive Service Task Force criteria for eligibility has opened up lung cancer screening to more at-risk populations. And so that's been something that we've been excited about, and we've directed some of our patient-centered efforts towards.
Wonderful. Yeah. So we're getting to the end of this session. And so I did want to allow you guys to maybe talk about what's going to happen in the future. So what do both of you see as the potential future direction for Lung-RADS in the next 5 to 10 years?
So, I mean, I wish I had a crystal ball, but because Lung-RADS is evidence based, we're really going to be following the data. And we're constantly evaluating the literature to determine what impact new findings may have on lung cancer screening, classification, and management. And so the reality is Lung-RADS is going to continue to evolve at the pace that new data becomes available. In some areas that may be accelerating, such as in AI applications. I will say that as a committee, we're going to be reevaluating a kind of systematic overview of ground glass nodules. There's new data that has come out over the past 5 years that we want to scrutinize. And that would include how to classify and manage nodules that may increase in density, but not necessarily size, and also have not yet developed a solid component, to give one example. We're also going to still be evaluating the role of volumetrics, making sure that it's appropriate and applicable. And I anticipate we'll provide clarification to clinical scenarios that may not be currently addressed by Lung-RADS, much like we did in version 2022. So I look forward to the future, and I just want to again thank all of the Lung-RADS committee members for their experience, their expertise, and all that they do to contribute to this important service.
And I will again commend Dr. Christensen. I will say that at every single Lung-RADS committee meeting, he brings forward questions that have come from users of Lung-RADS out in the community, out internationally. So when you write in a question or a comment, it's taken seriously and a lot of thought is put into it. And we do our best to try to respond to those questions and to keep them in mind as we make future iterations. So while this, is a committee that, meets to go over these criteria and to shape the way that it changes, it's really influenced by the larger community as a whole. And that's something that I really admire.
Thank you so much. Okay, so to conclude, can you summarize for our audience the major top-level takeaway from this statement from the Lung-RADS committee? And so we open it up with Dr. Christensen. Let's end this with Dr. Prosper.
We've got the addition of a totally new category to Lung-RADS, which is our atypical pulmonary cysts. We have expanded guidance for juxtapleural nodules, airway-centered nodules, and we've made clarifications about growth and how to assess growth between exams. We've also provided guidance on how to manage infectious or inflammatory findings. These are dynamic guidelines that change with the evidence. And so as we look forward to new iterations of Lung-RADS, we will be closely monitoring the output of the scientific community. We'll also be closely monitoring the comments and questions that we receive about our current version. So this is really a living document, Lung-RADS, and your committee members, 3 of which are before you today, are actively engaged in this process. And we look forward to the future.
So to conclude, thank you both so much for being here and your video article, which will be titled New Lung-RADS Statement, a talk with committee members Dr. Jared Christensen and Dr. Ashley Prosper. It'll be a great addition to the literature, I'm sure, and we hope it will be viewed often by our AGR readership. Thank you everyone for coming, and thank you to the audience as well.